Hello, my name is student Dr. Ashley Ryder, and today I will present the case of Danny. This is what we know about Danny. She is a 19-year-old Caucasian female. She is a freshman at a large state university. She has a boyfriend of 2 months, and she recently went to Arches National Park in Moab, Utah with her friends and her boyfriend. While at Arches, she went mountain biking and camping, and she said that she had a pretty crazy wipeout while at the park. Danny presented to our clinic with the chief complaint of fatigue and tingling in her fingertips. From the report, we also found that Danny has many other complaints, including difficulty sleeping. She also has some vision problems, like difficulty seeing PowerPoints from the middle of the classroom, occasional blurred vision, and double vision. She also noted that she has some occasional shoulder and neck pain, and difficulty concentrating, and with that, she's seen a recent drop in grades at the university. With these complaints, Danny has given us a lot of different symptoms to work with to start building a differential diagnosis list, but there's still a lot that we don't know about Danny. I have identified many information deficits that are pertinent to Danny's case. This additional information would guide my differential diagnoses and lead to a more definitive diagnosis. Given the opportunity, there are several other questions that I would like to ask Danny. First, starting with the timeline of events. It is really uncertain at this point how long ago her wipeout occurred and when she first started noticing symptoms. I would also like to ask Danny about the circumstances of her wipeout. Did she lose consciousness? Was she wearing a helmet? Are there any other symptoms that may have started around the same time or even before the accident? Are any of her friends experiencing similar symptoms? Any and all of these answers would be very beneficial in choosing my list of diagnoses. For my differential diagnosis list, I used DynaMed+ to search for conditions that fit some of Danny's most concerning symptoms. The symptoms I focused on were tingling of the fingertips, double vision, blurred vision, neck pain, and her recent history of trauma. Of my 5 differentials, I chose Chiari malformation as my working diagnosis, of which I will speak more later. Starting at the bottom of my list on the screen, I would like to check Danny's vitamin B12 status at a later time. This is not my primary diagnosis because the neck pain and the vision problems would remain unanswered, but vitamin B12 is not something that I want to discount. Next, chronic traumatic encephalopathy actually fits quite a bit of Danny's symptom profile, but Danny doesn't quite meet the typical age of onset. The average age is typically 42 years old. We actually don't know how many head injuries Danny has sustained, which is a huge factor. Multiple sclerosis is not my primary diagnosis at this time because of Danny's recent trauma and onset of her symptoms after the trauma. I wanted to include trauma in my working diagnosis. I also identified 2 possible causes of increased intracranial pressure. The first is idiopathic intracranial hypertension, and the second is subdural hematoma. Given the unknown timeline and lack of other emergent symptoms, I chose not to focus on subdural hematoma, and I really did not know enough of Danny's history to identify risk factors for the idiopathic intracranial hypertension. Therefore, Chiari malformation is my working diagnosis. So what is Chiari malformation? Chiari malformation is considered a hindbrain problem, classified by the herniation of cerebellar tonsils through the foramen magnum. There is a lot of variation among presentation from only tonsillar herniation to complete agenesis of the cerebellum. Chiari malformation can be congenital or acquired. Congenital Chiari malformation is often the result of a small cranial cavity. This can be due to a small posterior fossa, which is where the cerebellum actually sits, or premature suture closure. There are many complications as a result of tonsillar herniation. For instance, flow of cerebrospinal fluid, CSF, can be obstructed as the cerebellum compresses the 4th ventricle and cisterna magna. The CSF often collects in the central canal of the spinal cord or backs up via the cerebral aqueduct to the 3rd ventricle. Compression of the medulla and the upper spinal cord may also occur, eliciting further symptoms. Chiari malformation occurs in about 1 in every 1,000 individuals, and there is a much higher prevalence among family members. Research is currently underway to identify a genetic component. It is also possible to have acquired Chiari malformation. Hematomas are a candidate for causing this condition due to the increased intracranial pressure that they cause. This will cause the tonsils to herniate. Likewise, idiopathic intracranial hypertension may also cause this herniation. On the other hand, by reducing the pressure in the spinal cord via a spinal tap, this may cause herniation through the pressure difference. In Danny's case, she may have had Chiari malformation, but has been asymptomatic all these years until the trauma. Or she could have acquired Chiari malformation due to the trauma. It is also plausible to suspect that if the wipeout caused a head injury, Danny may have had increased intracranial pressure, which could have caused her current state of symptomatic Chiari malformation. If you'll take a look at the screen, in frame A, there is an MRI of a patient without Chiari malformation. The white is CSF, and you can clearly see that there are no tonsillar herniations. In frame B, you can see where the white arrow is pointing that there is a pointed cerebellar tonsil, which also shows the herniation of the cerebellar tonsil and possible obstruction of the fourth ventricle or cisterna magna. So how does Chiari malformation explain Danny's symptoms? A typical presentation of Chiari malformation often has a primary or chief complaint of suboccipital headaches, and these headaches tend to worsen with a cough or other Valsalva maneuvers. This returns us to one of the many information deficits of this case and one of the questions that I would like to ask Danny. Does she have a headache, or did she have a headache after her accident? Neck and shoulder pain are also common complaints for Chiari malformation. This is due to the compression of the cervical spinal cord root. This compression may also explain the sensory and motor loss seen in many Chiari malformation patients. Specifically, I would like to relate this to the tingling of Danny's fingertips. Double and blurred vision are also typical complaints and happen to match many of Danny's concerns. Some studies have reported cognitive impairment in Chiari malformation, and we may be able to attribute some of Danny's difficulties in school to this finding. Many of the symptoms associated with Chiari malformation are due to the CSF flow obstruction and will be discussed further. It is important to note that there are many different types of Chiari malformation, and I will discuss each briefly. Type 0 is controversial, but better described as having the symptoms of Chiari malformation, but not having any of the phenotypic expression, like the herniation of the tonsils. Type 1, which is what I believe Danny has, is characterized as having cerebellar tonsil herniation through the foramen magnum, but not having any involvement of the brainstem. This form is the most common. It can be congenital or acquired, and it can be asymptomatic or symptomatic, which explains Danny's presentation. Type 2 becomes more severe as we see cerebellar tonsil herniation and brainstem herniation through the foramen magnum. This is often accompanied by other conditions and often myelomeningocele. Type 3 is yet more severe. We see brainstem herniation through the foramen magnum, and often you'll see fourth ventricle herniation as well. The symptoms here are much more severe than you would see in type 1 and type 2 and typically requires a surgical intervention. Type 4 also tends to be controversial. It can be cerebellar hypoplasia or even cerebellar aplasia. This is all dependent on the literature that you read though. So how do I diagnose Chiari malformation? The gold standard for diagnosing this condition is an MRI of the brain and spine without contrast, and typically the entire spine is imaged. There are specific criteria for diagnosing this condition using an MRI. One cerebellar tonsil herniation of 5 mm or greater below the foramen magnum, or 2 cerebellar tonsil herniations of 3 mm or greater below the foramen magnum. Typically on an MRI, we will see pointed tonsils that have herniated instead of rounded. We saw this a couple slides ago earlier in the presentation. We may also see a smaller posterior fossa. A physician may order a CT of the brain and spine, but it is typically only ordered if you are monitoring the condition or if you are looking for certain bone malformations or hydrocephalus. Given the nature of Chiari malformation, there are several associated conditions. The most common is syringomyelia, which is defined as having cyst-like collections of cerebral spinal fluid in the central canal of the spinal cord. It is documented that 40 to 75% of patients with Chiari malformation present with syringomyelia, while 90% of patients with syringomyelia have a form of Chiari malformation. The cerebellar herniation in Chiari malformation can obstruct normal CSF flow and contribute to a syrinx. This syrinx can compress components of the spinal cord and has been noted to cause scoliosis, especially in children. Treatment for Chiari malformation is divided into non-surgical and surgical interventions. Non-surgical treatments include using anticonvulsants to treat neuropathic pain, antidepressants to potentiate descending inhibitory pathways for pain, and analgesics, and typically a combination of the above three is used. OMT is recommended to reduce restriction to CSF flow, and physical therapy can help with neck and shoulder stiffness. The recommended surgical treatment is a posterior fossa decompression. This occurs when a portion of the occipital bone is removed to give the cerebellum and brainstem extra room and reduce compression. This procedure has been shown to improve outcomes for syringomyelia as well. In this point in Danny's treatment, depending on whether or not the MRI shows cerebellar tonsil herniation, Danny may have a new diagnosis to explain her symptoms. With every diagnosis, there are always ethical considerations. If Danny is an avid mountain biking competitor, a neurologist may have to limit her participation due to the risk of further neurological damage. As Danny's physician, I would inform Danny of both the surgical and non-surgical treatment options, advising on the risks and benefits of both. The surgical treatment carries many risks, including CSF leakage, no improvement in her symptoms, or even damage to the brain or spinal cord. Beyond these risks, there are other aspects of surgery to consider, including aesthetics. The surgical site would be shaved and Danny would be left with a 3-inch scar. The typical recovery time is approximately 4 to 6 weeks before returning to work or school. With a new diagnosis of Chiari malformation, Danny has a lot to consider, but will of course be guided by knowledgeable physicians. I would like to thank the PTA team for their guidance in my presentation, and here's a list of my references used.